At this moment, I'd like to ask one of my friends and fellow board members, Jack Stibbs, to join me on the stage. Jack, are you there? To help present a very special award. Jack joined the PHA Board of Trustees way back in 1999, the same year that he organized PHA's first and largest research fundraiser. This now annual event, which has changed in format a little bit over the years, has raised over, get this, it's raised over $1.7 million for research of pulmonary hypertension. So Jack, I'd like to call you up to the podium.
I am thrilled to be presenting this award tonight. Each year, an outstanding physician who has been most notable in his or her service to PHA and in promoting excellent clinical care, research, education, and advocacy on behalf of PH patients is awarded the PHA Award for Excellence in PAH Care. It's hard to say, PHA Award for Excellence in PAH Care. The selection committee for this very distinguished award includes physicians, patients, and caregivers. The award itself is extraordinary in that it carries a $50,000 prize for the awardee's center to support continued excellence in clinical care. That prize, provided by Actelion, whom we thank very much for that, not only provides recognition for the awardee and his or her center, but it also shines the spotlight on pulmonary hypertension in the medical community and increasingly in the media. It is another way of saying that while our patient numbers are small, are not large, small that is, this is a community driven towards better treatments and a cure, a disease that needs to be watched and whose work is supported. This year's winner certainly fits the intent of this award. She is loved by her patients. She is revered and respected by her peers. I often wonder how she can do as much as she does and never seems to fall behind. I swear, I think this lady invented the term multitasking. I've never seen a person handle so much work in a day. Our winner is currently the director of the very large pulmonary hypertension program and professor of medicine at the University of Michigan in Ann Arbor. Go Big Blue. Her research focuses on pulmonary arterial hypertension, and she has been the principal investigator on numerous clinical trials. You would think that such an active professional life would be enough, but she is tirelessly contributing to the PHA community. She is currently the chair of PHA's SLC, the Scientific Leadership Council, and she serves as a member of PHA's Board of Trustees. She is also the past editor-in-chief of the Advances in Pulmonary Hypertension, which is PHA's official medical journal. She has been instrumental in the development of PHA's medical education fund, which has grown to offer, catch this, 90 medical education meetings this year for both patients and medical professionals. This physician defines excellence in her work with patients, her research, and her leadership in this community. It is therefore my honor to present the 2010 Award for Excellence in PAH Care to Dr. Vallerie McLaughlin. Val.
Thanks, Jack and Mike, for that lovely introduction. First of all, for those of you who are wondering, this is actually a different hot pink suit than the hot pink suit you see up there. I have like 4 or 5 of them. This is such an honor. I can't tell you how humbled I am. And there are so many healthcare providers in this room that are so deserving of this award, too. We all work tirelessly for this disease and for this community. I have a few groups that I would like to thank. One is really the patients. It's a privilege to care for you, and I'm inspired by your will and your spirit every single day. Second is all the mentors that I've had over the years, starting in 1995 with Stuart Rich, who is not here today, but kind of got me interested in pulmonary hypertension way back then. And it's continued along the way with many, many people, Lou, Robin, Mike, Greg, and many others who have mentored me, even though we've never been at the same institution. You've probably heard me say before, and I'll say many times again, I couldn't do what I do without my nurses. They're really the heart and soul of pulmonary hypertension programs. And back in the early days in Chicago, and Sarah, one of my nurses from Chicago, is here. And today my nurses at Michigan, Janice and Marcia, are here. And Sherry, Lori, and Heidi are back holding down the fort. But the nurses really deserve more of the credit than anyone gives them for in caring for this disease. I want to thank Reno and the PHA staff. You guys are just an incredible, dedicated, hardworking group, and you make it so easy to volunteer for this organization. There's so many friends in this room, I mean, people that I've met on a professional basis that have become personal friends. There's too many to name, you know who you are, but I appreciate your support every day. And last but not least, to my two beautiful children, who are here today. Kyle and Megan, who put up with my crazy schedule and are just the most wonderful kids you could imagine. And winning this award is great, but nothing is better than being your mom, and I love you. Thank you.
Well, getting an award for being excellent in healthcare is one thing. Getting one for being the best mom, I think, is quite another. I'd like to now introduce another colleague, Dr. Michael Mathier, Chair of the Scientific Leadership Council's Medically Led Sessions Committee for this 2010 conference. Dr. Mathier is going to tell you a little about the medically led sessions, as we call them, lined up over the next few days. Dr. Mathier is an associate professor of medicine and director of the Pulmonary Hypertension program at the University of Pittsburgh Medical Center. Mike?
Thanks, Mike. The medically led sessions are among the most popular features at conference each time, and we're confident that this year will be no different. We're very excited about what we have on store for you. Starting tomorrow, we have 40 different medically led sessions, and they involve over 130 medical professionals, and it ranges from physicians to physician extenders, nurses, therapists, and the list goes on. We added a number of new things this year. There are a number of new sessions, including things like stem cell therapy, sessions dealing with lifestyle issues, including alternative medicines, nutrition, exercise, and some things that reflect what's been going on in the disease state, such as treating very early forms of pulmonary hypertension and going over what we know about extending our therapies into new forms of pulmonary hypertension related to other diseases. One of the new things we added that I'm excited about is the Handout Book, and you will notice in your packet that there is a book that includes a handout from just about every medically led session. There's room in there for you to take notes. This is in recognition of comments that we've received from you guys over the years saying that you love the sessions, but it's frustrating that you can't go to all the ones that you want because they run at the same time. To further address that issue, starting a few weeks after conference is over, you will be able to find all of the sessions online so that there is no reason to miss any of them. So I encourage you guys, yeah, that's a very nice feature. I encourage you guys to attend these, to participate very energetically. I never worry about that here. From the very first time I attended one of these conferences, I was overwhelmed by the energy that patients and caregivers bring to these sessions. It's one of the most fun things that we do as physicians and nurses. And I hope you find them enjoyable, and I look forward to seeing you over the weekend. Thanks.
And we continue. Now allow me to introduce Dr. Richard Chanik, who will present this year's research awards. Dr. Chanik is Associate Professor of Medicine at Harvard Medical School and Director of the Pulmonary Hypertension Program at Massachusetts General Hospital in Boston. He is the current Editor-in-Chief of the medical journal Advances in Pulmonary Hypertension, which is a journal from the Pulmonary Hypertension Association. And at the conclusion of this conference, he will become the chair-elect of PHA's Scientific Leadership Council. Rich?
Thank you. One of the really great missions of PHA is funding research. And beginning in 2000, the PHA began providing research grants to young investigators as well as established investigators. 3 programs have been utilized for these awards. The first is the postdoctoral research program, which was designed to capture researchers really at the beginning of their careers. That was started in 1999, and in 2009 went in partnership with the American Heart Association. The second award is the Career Development Award, which began in 2003 and is in partnership with the NIH, NHLBI. And that provides research awards to early investigators, both clinical investigators as well as basic research investigators. Finally, we have the Pulmonary Hypertension Research Fellowship, which is really designed to enable new faculty investigators to make that transition, a very important and sometimes difficult transition, to become an established investigator in pulmonary hypertension. And that is now in partnership with the American Thoracic Society. And most recently, Pfizer has entered this partnership supporting the ATS portion of this funding. The partnership between PHA and its funding partners is really critical and more than doubles the amount of funding that flows to the awardees, enabling them hopefully to accomplish their mission. In fact, the programs have made commitments of over $9 million since the year 2000, all for research in pulmonary hypertension. And then finally, with a recent generous contribution from Dr. Robin Barst, the PHA is beginning to fund and will fund an endowed research program specifically in pediatric pulmonary hypertension that should be available soon. So on your screen is the list of the 2009 awardees, and on behalf of the Pulmonary Hypertension Association, I would like to congratulate them and ask any who are in attendance to stand up and be recognized. Thank you.
Thanks, Rich. Now, it's been a tradition at PHA's conference to have a physician give a presentation about the progress that's occurred over the past couple years in research and in clinical practice. And the idea is that if one physician presenting is good, then 2 presenting must be great. So this time, rather than having just one physician present, we will have 2 well-known physicians presenting to us this evening. As you will see during their presentation, they have a unique relationship. So please welcome to the stage at this point Dr. Vallerie McLaughlin, who quite literally needs no further introduction at this point, and Dr. Victor Tapson, Scientific Leadership Council member and Professor of Medicine and Medical Director of the Pulmonary Hypertension Clinic at Duke University Medical Center. Guys?
So actually, I want to tell the story of how this became two people giving this lecture. At CHEST last year, Dr. Tapson and I gave a side-by-side lecture like this with a little bit of banter at one of the evening symposia, and Reno saw it, and Reno thought that was kind of fun, might add a little flavor, and asked me if I thought we could do that for this. And, you know, knowing Vic, I knew he would do it. But I actually also knew that meant I would do it. So I knew how this was going to play out, and it did. So just so that you all know, we had a conference call, like what, a month ago?
Yes, I think for about 5 minutes, is right?
For about, yeah, whatever. And
then about an hour ago.
Right. So last week I text Vic, started to work on anything yet? Oh no, getting slammed in the MICU. And I'm like, okay, well, I'll put together a draft. And I emailed him a draft. And lo and behold, there's problems with email, and then there's traffic. And the first time he saw it, I think, was an hour before dinner.
It's really good, though. It's really good, though. You did a great,
So,
she did a great
so
job.
he added
Great
a couple
job.
things here and there. So this is totally unrehearsed, literally. So these
But
are.
it sounds like we have to banter, though, a little bit.
Well, you know
Just
what?
bantering, I guess,
We'll
right?
banter.
We're
We'll
gonna
banter.
banter,
I mean,
yeah.
I adore this man immensely, and he's going to make this fun.
Oh, thanks for the pressure.
We've come so far, right? We've come so far in such a short period of time. You see this timeline since PAH was first discovered and appreciated, and then nothing happens until the mid-1990s. And all of a sudden, in the past 15 years, we now have 8 FDA-approved drugs. We've had major world symposium. And we have a lot of investigational drugs. And to start out, we wanted to take a step back and tribute some of those people who really got things going. So one is Robin Barst. Is Robin here? Where is she? So Robin's a really special, amazing person, as you all know, and she's given so much to this organization and to patients with pulmonary hypertension, and she deserves accolades beyond belief. But tonight, actually, I thought I would tell you my most funny Robin Barst story. Do you have a funny Robin Barst story?
You go first.
Think of one quick. The funniest Robin Barr story that I can remember was at an SLC meeting when she was chair, I don't know what it was, maybe 3 or 4 years ago, and she wanted the whole SLC to bond, and this had been done at a board meeting, and so she wanted everybody to go around and tell something about themselves that no one else in the room would know. Well, little did she know that about 4 or 5 of those people would tell about the first interaction they had with Robin Barst, which was often her yelling at them for calling her, why is a fellow calling me, have your attending call me, or just the overwhelming initial experience, and it was hilarious actually if you were there, and I think Robin probably regrets that initial move, but we all love her and we all appreciate everything that you've done for pulmonary hypertension.
I just thought of one quick story. Actually,
Okay.
I just thought of this, but it's not, I don't know if it's funny or not, but I've never told anybody this story ever about me and Robin, and Robin doesn't really even know about it. So Robin, we had a meeting in London, I don't know, it was not too long ago, an investigator meeting, and after the meeting, we were kind of both heading to the airport and walking the airport. So we were kind of walking together. It was a pretty long walk. I don't know if you remember this, Rob, but I was thinking, I'll walk slow. Robin's got high heels on, and I couldn't freaking keep up with Robin. So I'm carrying pushing my suitcase along. She's walking. So I've never told. I stopped and pretended to have to go to the bathroom just because I couldn't keep up with her. Unbelievable. Anyway, I'm embarrassed to tell that, but I feel like we're all friends. So.
So the next very senior person we want to tribute is Stu Rich, and I could sing accolades about Stu. He's the one who brought me into this field in 1995, and he really was the best mentor that anyone ever could have. And we're, even though I left Chicago 7 years ago, we're still good friends, and we still talk. I still love to run a challenging patient by him, and I think he's just contributed so much to this community also. And I'm not going to tell any funny stories about Stuart. I don't know if you have a funny story.
No.
Okay. And now, I think there are no funny stories about Lou Rubin. No, that's a joke. Lou has sort of been my mentor away from home since I left Chicago, and Robin, Stewart, and Lou really were the original three that got a lot of the drug trials going back in the early 1990s. And again, Lou has contributed so much to patients with this disease, and we want to pay a special tribute to Lou because he's sort of semi-retiring in August. He's going to stop seeing patients in August, which is a tremendous loss for the PH patient community, but he'll continue consulting and hopefully with the drug development to help us move further along.
Yeah, and Lou's not here, am I right? Lou's not here?
I don't think he's Lou here. You want to tell something?
Well, yeah,
funny?
now he's not here.
Okay, he won't hear about it.
I'm
He won't
kidding.
hear about it, don't worry.
No, I'm not going to tell a story. Just to give a perspective about Lou, Lou did some of his training at Duke before I got there. And we had him come back to Duke to give grand rounds a couple of years ago. It was actually 2005. And so he published a paper in New England Journal on hydralazine and pH in 1980. So the 15 years before Flolan was approved. So just to give perspective how long Lou's been involved with this disease, he's been a mentor of mine as well, even though I've never really worked directly with him. So it's wonderful to have people like Lou and Stu and Robin and Greg Elliott, Mike Magoon, and so many others to be able to have learned from over the years.
Yeah, absolutely. So, well, we've come a long way, and we all appreciate the progress that we've made. We all appreciate the involvement that pharma has had in developing drugs and doing research trial and getting therapies to market. We still have a long way to go, and we're not stopping where we are. These are survival curves from the French registry. This is a current day registry of patients with pulmonary hypertension getting state-of-the-art care in France. And those are survival curves for prevalent patients, so that means patients who come into the registry already being diagnosed, already being treated, and incident patients, so that's newly diagnosed patients. And while those are better than they were, they're still not perfect. We still haven't cured this disease. We still haven't adequately treated it in a lot of patients, and so we still have a ways to go. And one of our ways to attack this is with combination therapy, and we'll see that many patients are on combinations of our currently approved therapy. And this is a slide from the REVEAL database. And REVEAL, as you all know, is a large multi-center US database that is really just looking at patterns in patients with pulmonary hypertension. And the last person that we really want to pay tribute to is Mike Magoon. And Mike is the chairman of REVEAL, and we're going to learn so much from this.
And that's the way he usually dresses, by the way. He's kind of toned it down for this meeting, but that's the way he usually dresses.
Now, I'll tell you, this is actually one of the least incriminating pictures of Mike that was sent to me when I was collecting pictures. There was Unabomber Mike, which I just couldn't show it in front of 1,200 people. And then the last ATS was at New Orleans. And there were pictures of Mike in the street with characters from New Orleans, and I didn't really feel comfortable putting any of those up. But we all adore Mike, and again, he's one of those individuals that has made such tremendous contributions, not only to the field of PH, but also to this organization, one of the truly most dedicated members of this organization that we have. Now, how can we come further? We still have a lot of work to do, and one thing that we always talk about is what are our models of pulmonary hypertension? Well, the monoclonal rat model is really not a patient with pulmonary hypertension, and this is an initiative that we hope will make a breakthrough. This is what we call the Pulmonary Hypertension Breakthrough Initiative, and this is a study that is funded by monies that were put aside out of the class action diet pill settlement that happened about whatever it was, 10 or 15 years ago. And with this study, and you can see this is a multi-center, very collaborative study. Some of the leading pH experts, both in clinical science and basic science, are involved. And we're taking the lungs of patients who are undergoing lung transplantation. So these are really patients with pulmonary hypertension. It's real human tissue that we're getting into the hands of scientists. And so far, we've harvested 42 sets of lungs and processed that tissue and gotten that into the hands of scientists. And they're really starting to make some important discoveries. And we hope that someday, by studying human tissue, that will lead towards a cure.
And we've come along. Oh, is it my turn?
Yeah.
Okay. We've come a long way with transplants. Some of you may have had transplants here. I know we did more than 100 lung transplants at Duke last year. We're shooting for 200 this next year. Cleveland Clinic has been very busy with transplants, an exciting area. I was rounding on call a couple of weekends ago and was rounding on the transplant patients on the weekend and ran into a patient I hadn't seen for a while that was transplanted 15 years ago. So again, it's tough to go through a transplant, but we've come a long way. We've come a long way. So for a couple of minutes, we'll talk about investigational agents for PAH. Some of you may be on some already. There's a lot of sessions about medications and various approaches to PH this weekend to learn from. I'll just run through a couple of quick things, and don't worry too much about details, but just some new drugs you might not have heard of. Riociguat's one. That's a soluble guanine cyclase stimulator. We don't have a drug of that class yet. We've got endothelin antagonists like bosentan and ambrisentan, PD5 inhibitors like tadalafil and sildenafil, and of course the prostacyclin drugs like Flolan and Remodulin. But we don't have one of these class drugs yet. So we're excited about riociguat. There's clinical trials underway right now.
And I think while we talk about clinical trials, it's a good opportunity to take a step back and really acknowledge the role of all these patients in clinical trials. We wouldn't have the drugs that we have. We wouldn't be able to enroll the clinical trials if it were not for all of the patients that have been willing to participate in clinical trials. And so we thank you. The whole community thanks you for that.
Absolutely, sure. And it's not easy. I mean, you come to clinic, come extra time, you're driving hours sometimes to do this, and sometimes there may not really be anything in it for you. On a particular visit, just something's demanded by the study. So again, we really applaud you for helping us get it. We wouldn't have these FDA-approved drugs without you guys helping us out, and helping each other out. Selexipag, a fascinating drug. It's kind of like a prostacyclin, not really a prostacyclin class drug, but it hits the prostacyclin receptor. An agonist means it hits that receptor and activates it. So we have IV prostacyclins now, inhaled prostacyclins. We don't have an oral one yet, but hopefully one's coming soon. And the Griffin Trial is underway. And here's a little information. You don't have to worry too much about details here, but the blue just shows the placebo effect and the red effect by the drug, and on the column there with the numbers, that just basically shows how patients have done with their pulmonary vascular resistance. We want that to go down. It's kind of like the pressure, want that to go down, and the drug seems to work in a small preliminary study. So we'll get more information soon. Mastatin is a fascinating drug. It's an endothelin receptor antagonist like bosentan or ambrisentan, like trachlor or teres. But it's a little different. It's tissue selective. It sounds like it may have some advantages. And there's a huge study called Seraphim some of you may be involved with right now. We're very excited about getting this study done as well. Another very interesting area, again, in the oral prostacyclin area, oral treprostinil, the Freedom Trial. We finished the first aspect of the Freedom study, and just what we'll show you here in a nutshell is at 16 weeks, at 12 weeks it looked pretty good. At 16 weeks it didn't quite reach statistical significance. The walk distance didn't improve enough to reach significance, but we learned a couple things from this study, and there are more ongoing studies with this drug. We learned, for example, if you get that dose to a certain amount, it does seem to help. And if there's a smaller pill availability, because this drug causes nausea if you go up on the dose too fast, patients seem to do better. So these are some clues that the next studies may in fact be positive, and we'll see what happens. We're excited about this one as well. This one, maybe Val, you should talk about it. It's pretty complicated. Anyway, there's these drugs called Tyrosine Kinase. Exciting drugs. They've been used for cancer. Chronic myelogenous leukemia, CML. They work really well for these cancers. And we've got a couple of drugs. We're doing a study with imatinib. It's imatinib, not imit, but anyway, that's Val's little misspelling there.
Sorry.
Nice going there. I'm sorry I didn't look these over ahead of time enough, but anyway. So nilotinib, sunitinib, these are drugs in the New England Journal paper this week on a couple of these drugs again for advanced cancers. But we're really excited about these drugs for pulmonary hypertension. Again, a new mechanism we haven't really used before. So preliminary data suggests in some patients, even those already on aggressive therapies, taking So we're excited about kinase inhibitors as well, and that.
Now, one problem that we come to with clinical trials is because there's so many agents out there and there's so many doctors treating, we're starting to run into trouble enrolling clinical trials in a timely fashion, which is unfortunate, and opportunities like this to share the trials with everybody is great, because that way maybe you can learn more about who might be doing them in your area and find out whether or not you'd be a candidate to enroll in any of these trials, and if we can get them enrolled, we get results, and hopefully we get drugs out there sooner.
Absolutely, Rob. So what are our treatment goals of PAH? Well, here they are, and I think these make good sense. We want people to feel better. We want people to exercise, be able to exercise better and do more of their daily activity. We want them to live longer, but have a better quality of life and prevent worsening. So these are our goals in these treatment studies. And one thing we've talked about in the past is maybe it's helpful in PH to get aggressive up front. We tend to start with one drug, add another drug. Maybe we need to consider, like cancer therapy. You blast somebody out of the water that has leukemia with a bunch of different drugs, and they go through a tough period of time, but it may improve survival. Now, these drugs have side effects. Something like this has to be done with caution, but one of the thoughts in PH is maybe we ought to start with 2 drugs at a time or 3 drugs rather than adding a drug if someone gets worse. There's a new concept of goal-oriented therapy. I shouldn't say new, but kind of new, where you don't necessarily have to wait till someone gets worse to add a drug. Maybe if they're just not getting better, but not functioning at the level where you want. So maybe they're no different, but not quite where you want them, we add a drug. So a lot of new concepts in PH that you've probably run into, somebody may have run into already with your physicians.
Yeah, and this is a really interesting concept. I mean, some of our strongest therapies for pulmonary hypertension are the prostanoids, but they're also the most complicated. So oftentimes if a patient is not really critically ill, we let them start on a pill first. I mean, it's certainly easier for the patient. I've yet to meet the functional class 2 patient or the functional class early 3 patient that I say it's okay to start the pill and they say, oh no, please give me the pump. Has that ever happened to you?
Not that often, no.
So that's one of the things that makes this really kind of not feasible. I mean, it would be really hard to enroll a study of patients that were not so sick that they needed IV therapy right away and randomize them to receive IV therapy or to receive oral therapy. So while conceptually we would love to know the answer to this question, we'll probably never get that sort of induction therapy study done, but maybe there's another approach that we can take.
And right now, it seems that our IV therapies, or aggressive therapies with intravenous lines and pumps, seem to be our strongest, most potent therapies. But again, there are these oral prostacyclins coming out soon and drugs of other mechanisms. So we're hoping we won't need IV therapies at some point, but we're not sure yet. We'll know in time. We'll know in time. Ambition is an example of a study that's getting off the ground here. And this is a study where we're starting with 2 drugs at once, ambrisentan and tadalafil, compared with 2 other arms in which you'll get 1 drug. So we'll get an idea whether starting with 2 drugs at once is better. I think this is a step in the right direction to learning this. So we should get more aggressive therapy?
How many patients in the audience have heard about this Reveal risk calculator thing? Anyone know about that yet? I think you're going to hear about it. And Mike, who obviously is the chairman of Reveal, is instrumental in this. And Ray Benza, the calculator is Ray's thing. I thought it would be fun to give a special tribute to Ray, not only for his work on the calculator that we're about to talk about, but also his climb on Kilimanjaro. That was obviously amazing. And if Jess Lazar is here, I have to tell you, Jess, I heard Ray Benza do the Bob Marley, Don't Worry, Be Happy, long before you did. And in fact, I can safely say that Ray Benza is the person at this conference who knows me longer than anyone else, knows me longer than you. Ray and I were residents together in 1989. We started our internship together, so we go a long way back, and I'm really proud of the work that he's done on this. But this is the Reveal risk calculator, and we won't go through all of it, but suffice it to say that one of the things that is being investigated in Reveal is what sort of things predict how long a patient will live. And for the patients, just remember these are broad generalizations. These are looking at a whole hundreds and even thousands of patients with a particular characteristic and saying what proportion of those patients live this amount of time. And so I think when this comes out and, you know, when you ask your doctor, gosh, what's my REVEAL risk score, you have to kind of put that in perspective. I mean, this is big population data, and how it applies to just one individual person needs to be sort of put in perspective. But there are things that have been learned from REVEAL that predict a patient's not going to do well, and some of them are common sense. I think that both Vic and I would agree that a patient with a PVR of over 32 is in, or whatever the number is, I don't remember exactly, but is in trouble. It's high, yeah. I mean, some of this is really common sense, but it puts it together in a very scientific way, and it puts patients into different strata based on the score that they get, and then it kind of predicts their 1-year survival. And so it's really useful information on a population basis, but you have to really think about the limitations of applying it to one individual patient. But one of the things you might think is, gosh, if someone has a high REVEAL risk score or a score that is going to predict a poor prognosis, should we be more aggressive with them? And I think that's one of the things in the REVEAL database that is going to help us manage our patients, and obviously we'll have to learn this over time. There's some things that are popping out from both REVEAL and the French database that portend a worse prognosis, and some of them are listed here, and many of these things are things that are measured every time you see the doctor or the functional class. In most instances, the 6-minute hall walk. Other things aren't measured every time. You don't get a right heart cath every time, but it's important to kind of assimilate this data and figure out how to treat people. And there may be a lot of people who have a high risk with the REVEAL risk score, with the French registry equation, who are not getting the optimal therapy. And this is, again, data from REVEAL that shows a very large proportion of patients with functional class 3 and 4 symptoms still aren't getting prostanoids, some of the most therapeutic, most powerful therapies that we have. So I think taking this data and applying it to the general population will be really helpful for our physicians and our patients to work together and try and optimize therapies.
Yeah, the risk score is exciting. I mean, we kind of do it already, but this might be a more precise way to learn things. In other words, we ask you how you feel, we listen to your heart, we hear it sounds, we hear the extra heart sounds, gallops. Is your heart more enlarged? Do you have more swelling in your legs? What does your echo look like? How big's your heart? How well is the right side of the heart pumping? What's the pressure? What's your BNP value? We look at all these different
things. He does that all in his head in about 20 seconds.
Well, no. So we kind of do it right. But this calculator is kind of cool because it really might be a way to not just kind of estimate it, but maybe get a more accurate way of looking at things. So it's exciting to study further.
So that helps us kind of figure out how to manage patients, and maybe we should be a little more aggressive. Maybe we shouldn't wait for patients to get sicker and sicker and sicker. Maybe we should be proactive and more aggressively treat patients who don't meet those specific goals. And I think we're going to learn about that as time goes by. Now, I was closing. I had this great picture of two of my dearest friends, dearest personal friends in this community, Rich Chanik and Vic Tapson, this picture that was taken at some event that I wasn't at. And I thought it was a great
Somehow
picture.
it got kind of left out of the presentation. I don't know how.
Well, it's fine. It's fine because with the looks on their face, it was clear they were drinking till 4 in the morning, and I couldn't have kept up with them anyway.
Rich, we were sleepy, weren't we? We were sleepy.
But so Vic took my memory stick and he took that picture out, and so now come the slides that I have not seen. So Vic's going to close it with one.
No, I wouldn't do it. Wouldn't do it too well. So we love our patients so much, and we want to do everything we possibly can for them. But I think it's okay to be a little silly once in a while and have some fun. And so I thought we'd do a little short limerick. PHA offers wisdom and hope when you feel it's a slippery slope. When you need a good friend, PHA will transcend and pull you up from the end of your rope. And thank you for Reno and Carl Hicks and Jack and all the folks involved with PHA. What a wonderful organization. Top 2% of charities. That's unfrickin' believable. I'm allowed to say frickin', right? That's not a bad word.
Don't say that. There's kids here.
As PH soldiers, all of us vie to someday kiss PH goodbye, so none of us see a failing RV or PA pressures that get up so high. As doctors, we all work a ton, missing meals, sleeping, nightlife, and fun. We get all the praise, but in so many ways, with just us, it would never get done. Our nurses are saints, it is true. Drug approval, check the labs, and call you. Cath results, IRBs, work Saturday, please. The weary don't rest till they're through. And they're never through, and they never will be through. We love them. And Crystal from Duke is here, Abby's not here, but so many nurse coordinators are here, and we really do thank all you do. It's amazing what you guys do. They are patient, hardworking, what luck, always smiling while they're loading the truck. Patient pain and emotion gets love and devotion. Without them, my job would suck. So it wouldn't be proper to close without honoring these PH pros. When I finish these verses for our PH nurses, a round of applause I propose. Thank you. So enjoy these few days in LA, and forgive me for sounding cliche. Don't be talking, no action. You'll get satisfaction. Help us keep paving the way. Val, thanks for being up here with me. You're a queen of PH, all agree. I hope in 10 years we've allayed patient fears and PH is just past history. Thank you. Thank you very much. Are we done? Thank you, Val. Congratulations. Thank you.